All right, we'll start now.
A very warm greetings to each and every one of you. It gives me an immense pleasure to extend a very warm welcome on behalf of Christiodi College of Management and Technology, Changanasheri, Kerala. Christiodi College of Management and Technology, Changanasheri is affiliated to Mahatma Gandhi University and is recognized by the University Grants Commission (UGC). The college also has a range of facilities and resources to support students' learning and development. In addition to academic and extracurricular activities, Christiodi College also places a strong emphasis on community service and social responsibility. The college encourages students to participate in volunteer work and social service projects, helping to develop a sense of civic responsibility and social awareness. The postgraduate Department of Psychology, in association with IQAC, has brought us together for the webinar on the topic Process-Based Psychotherapy, Shifting Focus from Syndromes and Protocols of Treatment. I am Anu and Abraham, the MC of the event. On behalf of the organizing committee, we extend our appreciation for your valuable presence today. Prayer is the steering wheel that directs us towards the right path throughout our life. Let's invoke the blessings of Almighty. I call upon Ms. Meenakshi Pinaya for the prayer song. Now I would like to welcome Ms. Juliet C. Paul for delivering the welcome speech.
Ma'am, could you confirm if I'm audible, please?
Yes, Juliet, you're audible.
A very good afternoon to one and all present here. Respected Principal, Reverend Father Joshi Chiramkuri, CMI of Christajodi College of Management and Technology, well-claimed guest speaker, Dr. Gitanjali Natarajan, our beloved section head of the department, Mr. Sijo Joseph, all the delegates and faculty members. It gives me immense pleasure to extend a very warm welcome to you on behalf of the Postgraduate Department of Psychology, KCMT, who has clubbed us together for this webinar on the topic Process-Based Psychotherapy, Shifting Focus from Syndromes and Protocols of Treatment. Taking this afternoon further, I, on the behalf of the Postgraduate Department of Psychology, KCMT, and everyone else present here, would like to heartily welcome our resource person of the day, Dr. Gitanjali Natarajan. Dr. Gitanjali Natarajan is the Chief Clinical Psychologist Advisor of Niyama Healthcare, Clinical Professor at Amrita Institute of Medical Sciences, Kochi, as well as a private practitioner. We welcome you, ma'am. Further, I would like to welcome our Principal, Reverend Father Joshi Chiramkuri, CMI, even in his absence. The courage to make tough decisions and the compassion to listen to the needs of others is an art, which our dear Principal has done full justice to. He has been our constant pillar of support and has provided us with proper guidance in all that we do. We welcome you, Father. Next, it is my turn to extend a gracious welcome to our sectional head of the department, Mr. Sijo Joseph. It is a sense of commitment which creates an apt platform for us to grow both mentally and spiritually. We welcome you, sir. Also, I would like to heartily welcome our faculty coordinator of this event, Ms. Sharon Jose, who has taken great amount of efforts in putting together this event in an organized manner. We welcome you, ma'am. Further, I would like to extend a hearty welcome and acknowledge all the delegates that are present here today in order to attend this webinar. We are delighted to have you with us, and I wish all of you the very best and hope that this session will prove to be informative and useful for you. Once again, I welcome you all. I also take this opportunity to honor and welcome our dear teachers who chisel and shape our lives to be good citizens of the society. Undoubtedly, your sense of commitment, sacrificial service, immense patience, and responsibility play a key role in our growth. We welcome you, dear teachers. Once again, to all of you, thank you for being here. Welcome and have a great session.
Thank you, Juliet, for your words of welcome. Now we are about to move on to our session. Before we begin, I would like to remind certain things regarding today's session. They are, the programs will be recorded and the live streaming will be available on our YouTube channel. So participants who couldn't join the Zoom meeting can listen to the YouTube streaming. You can ask any query to the resource person by using the Q&A feature at the end of the session. Participants are requested to kindly wait till the end of the session. Feedback forms will be provided at the end of the session. Please make sure that the feedback forms are filled in order to get certificates. Next, I call upon Ms. Sharon Jose, Faculty Coordinator for the event, to introduce our resource person.
Am I audible?
Yes, ma'am, you're all.
All right. Thank you, Anu, and good afternoon, everyone, and welcome to the webinar on process-based psychotherapy, shifting focus from syndromes and protocols of treatment, organized by the Postgraduate Department of Psychology of the College of Management and Technology, Chengalasheri. It is my honor to introduce the Chief Resource Person for the day. We have with us Dr. Gitanjali Natarajan. She is the professor in the Department of Clinical Psychology under the Institute of Medical Sciences, Kochi. She's also the Chief Clinical Psychology Advisor of NEMA Healthcare, and she's also a private practitioner. For the last 17 years, she has been working in the area of adult psychopathology and psychotherapy, acceptance and commitment therapy, CBT, interpersonal psychotherapy, marital and family therapy through a process-based approach. She has been instrumental in starting the first RCI-approved MPhil clinical psychology program in Kerala in 2015. Prior to joining AIMS, she was a consultant clinical psychologist at Lakeshore Hospital and Research Center, where she started the Department of Clinical Psychology. She completed her PhD in clinical psychology from Amrita Institute of Medical Sciences and MPhil in clinical psychology from the prestigious NIMHANS, Bangalore. She was the recipient of the Fulbright Doctoral and Professional Fellowship with placement at the Social Relations Lab at Columbia University, New York. Dr. M.V. Govindaswamy Memorial Prize for Best Outgoing Intern in MPhil, and Alexander Memorial Award for Meritorious Performance during graduation at UC College, Alvi. She has been the General Secretary of Indian Association of Clinical Psychologists, Kerala region from 2016 to 2019, and the Executive Council South Zone representative of IACP from 2017 to 2019. Now, she was also a member of the National Task Force for Psychotherapy Supervision in India. She is a board member of Association of Contextual Behavioral Sciences, India chapter. She is passionate about practicing and disseminating knowledge about ACT and process-based approach to mental health professionals in India. She has several articles in peer-reviewed journals. She has constructed and validated the rejection-sensitive expectations, perception and reaction among intimate partner questionnaire, which was published in the prestigious Journal of Marital and Family Therapy. She has also written a number of articles in newspapers and magazines for public awareness on mental health and psychosocial issues. She also appears regularly in the health news of Amrita channel, and she's also a panelist in other channels to talk on various mental health topics. With utmost respect, I call upon Dr. Gitanjali to share her worthy knowledge and experiences. Ma'am, please.
Thank you, Sharon. I'm really happy to be among all of you. Thank you, the management of Christujoti, for inviting me. And I would be happy if some of you at least put on your videos so I can see your expression, your beautiful faces. So what I intend doing is to present something that I am also learning and I'm very curious about. And as we go about the presentation, I generally always think I should keep my slides very simple and not fill it up with a lot of material, but I end up doing exactly that. Probably it comes from my anxiety levels as well as maybe my wanting to share as much information with you. I'm not sure whether I have actually toned it down to suit undergrads or whether it is suitable for PG students or maybe professionals. Also, some of these things may seem new to them. But so what I want you to do is just sit back, relax, and just go through whatever we are discussing. Don't try to understand each and everything that I am presenting. All that I want to create is some questions in your mind. You can always go through textbooks and other things later. I can always come back again and focus on specific aspects which I have presented if you want it in detail. So I want you to just relax and go through the presentation. Don't try to understand and memorize or write down everything that you see. Okay. Let me share my slides. Hope you're able to see.
Yes, ma'am.
Okay. So I won't go into the topic again, but this might seem a little offhand compared to the usual topics that are presented about psychotherapy. So what I plan to cover in our brief time together is touch upon psychotherapy itself and what is it that clients come in search of. Then talk about syndromes, then move on to why we need to move away from focusing on protocols for syndromes or syndrome itself or disorder itself, and why we need to look at what really makes the changes. And finally, talk about what is process-based therapy. So to quickly find out, give me a minute. Will I be able to see if someone types into the chat?
Yes, ma'am. Yes, ma'am, you will be able to see.
Okay. So what is it that clients come to when they come for therapy or when they come for counseling or when they come to a psychologist with problems? What is it that they are looking for? Are they looking for diagnosis? Are they looking for understanding? Are they looking for solutions? Can you type into the chat quickly? One that you feel is the most important. When I say understanding, it could be understanding about oneself, understanding from the therapist itself. I would urge students to be on the chat and then type off whatever comes to your mind. They're looking for to be understood. Yes. What about they don't want solutions? They come with a problem, they do want solutions, right? Because after understanding, they automatically get a solution. Okay. Right, you're right. They do want to understand why they are experiencing these problems, and they want to feel validated, and they want to find a solution to whatever problem that they have. When we say problem, it necessarily doesn't mean that they are all coming with mental health problem or distress. It could be anything related to life, that the problem which is stressing them out, they come to the psychologist to help them learn skills to handle that. Because in psychology, behavior, 70% treatment is of anything. Some people might have solution to their problem, but they are not able to implement this. Absolutely. Now, if we go on to what makes you capable of helping the person who has approached you? What is it in you that makes you capable of? Is every person capable of helping the other person? A lot of times we do talk to our elders, sometimes neighbors, but what is it that makes a psychologist a cut above the lay people in a way that you can help them? Something professional about you. So what is it? Is it training? Is it your ability to be empathetic? Is it your communication, therapeutic, and social skills? What do you say? Social skills, way of talking. Anything else? What if we only have social skills? Very good in communication, very good in talking. You don't need to be trained in evidence-based treatment methodologies. Again, all these are important, right? And much more. So this is, you don't have to read everything, but you can make out that there is a whole list of treatment. These are treatment manuals and evidence-based treatments, which are listed in the APA or American Psychological Association, Psychiatric Association website. So if you see, there is around 86 different evidence-based therapies for different conditions. And it's not humanly possible for, at least I think so, that for any person to be know all these treatments, as well as be, and then comes the question of being an expert at delivering these treatments. So what is the solution? We all psychotherapists struggle with this problem of tailoring our interventions to the client. We strive to manage each of, we strive and manage this problem in our own way, in our own, through our own journeys, and trying to fine-tune our therapeutic skills, and so that we can tailor our interventions for the client and do best practice. But there has to be a way in which we don't need to learn. There are almost 500 or more evidence-based psychotherapies. And with each day, a new person is finding a new psychotherapy and they are propagating for it. They are conducting workshops, and then we go and learn that also. And when we are learning, we feel that, okay, now this makes sense. And then we go and learn something else, and then we feel that that also makes sense. So it is high time that we addressed this issue of being able to have a clear scientific methodology in which we can tailor our interventions in an evidence-based manner. It's not the haphazard eclecticism that we follow where, okay, now I feel that this intervention might be good, or it could be that I only know relaxation exercise, so I give relaxation exercise to everybody. That is not the scientific way of delivering psychotherapy. So before we go further, let us look at what syndromes are. I prefer the word syndrome to disorder. The disorder actually means that something is not in order. And so who decides what is in order? What is your take on that? Anyone? When do you say something is in order, and when is it a disorder, and who decides what is in order? There is no simple answer to it. We need to really know whether these syndromes itself or these packages which put together signs and symptoms, are they real? Are they valid? You can see this jackfruit here. Nobody will deny that it's not real. There is evidence. You can eat it and feel the sweetness. You can touch. Or take, for instance, kidneys. Nobody can deny that the human being has kidneys. We may not be able to see our kidney, but definitely it's functioning and we feel the effect of it. And if we have to undergo an operation or there is research and then cut open and the kidneys are there, right? So they are real. You can touch, you can feel certain real things out there in the environment. But what about depression? What is depression? Is that real? What do you say? You can just say yes, no, yes, no. Is depression real? Is there something which is whole, real, out there, which can be said, okay, this is depression? So depression is a name, is a syndrome given to a set of symptoms. In my view, depression is nothing. Okay. So there are a lot of people who suffer from depression, and depression as such is, just to use the most commonly used mental health problem, is anxiety and depression. So what is depression? What is real is that the early experiences that the person has, the way the person thinks, how much of their thoughts are helpful, positive, and energizing, how much anxiety levels are they experiencing? Are they feeling stressed? Do they feel distressed? Are they sleeping well? Are you eating well? Are you able to do productive work? Those things are real. And depression is a label that we give when a lot of these things don't come together or work together. A lot of times we end up speaking about mental health problems as if, say, for instance, I broke up depression for you. we cannot say, I have depression, which is very commonly said. But that is how most of the labels or diagnostic labels are used. For instance, I have borderline personality disorder. That is a diagnostic label. But over time, what happens is, nowadays, I think the most commonly diagnosed personality problem for females is emotionally unstable personality disorder or emotionally unstable personality. I would say that it is women who try to break out of the clutches of the society, which is keeping them suppressed, and their voice, which is misconstrued as emotionally unstable. Why not? So it is very convenient to give a label and diagnose a person, but in the process, we are actually not understanding human suffering. Really human suffering in all the things that the person has gone through in life, what is currently happening around the person, and the person's struggle to exist is often not understood. What has all this biomedicalization done? It has actually, one side effect was increased use of medications. And lot of billions of amounts have gone into research to find disease. Unfortunately or fortunately, no disease as such to date has been identified in mental health. The former head of the NIMH eventually concluded that the 20 billion spent on this approach actually did not improve outcomes. Isn't that why so much research happened? If we can reduce the number of people with mental health problems, reduce people who need inpatient care, improve quality of life, improve resilience, but unfortunately that has not happened. Categorizing people into syndromes and sub-syndromes. That's what our ICD and DSM does. And over the years, the bulk of the books have kept increasing. And over the years, the number of categories have multiplied. And this search for a latent disease, that there is something wrong in a person's brain and that is causing the mental health problem, has been a defeatistic search. Syndrome-based protocols leave us feeling, and one of this, as this happened, CBT benefited quite a lot because CBT was, unlike behavior therapy or unlike cognitive therapy, CBT protocols catered to syndromes. For instance, if you see, there are a lot of manuals for CBT for eating disorder, CBT for depression, CBT for social anxiety disorder, CBT for OCD, CBT for... So somewhere proving that a particular cognitive behavioral package was helping change or resulting in improvement, also served the purpose of proving that there is a disease, latent disease out there, which can be addressed with a protocol. But these protocols, unfortunately, undermine human differences. Because CBT typically works with a particular conceptualization, which is fitted for every individual who is diagnosed with that problem. But if you take 2 or 10 people with social anxiety disorder, not everyone would have similar kind of social anxiety. One person could have difficulty speaking to familiar people, another to strangers, another person, it would be performance anxiety. You could have yet another person who's not avoiding anything, but there is high levels of anxiety. A 5th person who tends to not express that they feel anxiety, but there is high levels of avoidance. So what will account for these individual differences? A single protocol of CPT protocol does not do that. And also in our society, we have this feel-goodism, an intolerance to all negative emotions, and as if happiness is the state to be. A byproduct of that is more and more people go for quick fixes. Somehow they want to find happiness and end up a lot of people who struggle with unpleasant inner experiences, and they get close to those, and in the search for quick fixes might end up not really focusing on what is troubling them, what problems they have in their life, what I need to do to make changes in my family. Do I need to make major decisions concern my career? And then a quick fix could be treatment, any kind of treatment, say medications or any other treatment. But then somewhere the person is moving away from their own inner experiences and ability to cope with their own emotions, feelings, and behavior. What we need is in psychotherapy, in mental health care, what we really need is a very individualized approach, an idiographic and individualized approach, where our interventions are taking into consideration the whole of the individual, and also what the problems are and what treatment would best fit, or treatment or management or skills would best fit that individual. To come to about a protocol for processes, protocol to processes. Why is it necessary that we move towards understanding what is really causing problems in the person? What is it that needs to change? Let's just see one history of a person, 30 years old, unmarried male. It's an IT professional presented with worry of losing hair, insomnia, and looking tired and awkward. He could not relax around people. He also stopped going to the gym. Repeatedly checked his image in the mirror. He avoided taking up overseas posting and generally felt hopeless and sad. So here, what all can we make out in the person? We can make out that he is anxious, he's worrying, he's feeling helpless, there is avoidance behaviors, and there is also compulsive behaviors. So I can challenge no one particular protocol which was there in that 86 list of 86 can really comprehensively help this individual. We will have to find interventions which are tailored to suit this person, to help him understand processes which are maladaptive and learn processes which are adaptive. So not everybody will benefit from a protocol, and how can we effectively treat every person? We need to know what works for whom and why. Again, evidence-based alternatives to stringent protocols. Why should we need interventions which are evidence-based and not protocols or like manuals? A same clinical presentation, for instance, depression, can have different processes. One person with depression can have predominantly low energy and lack of interest. Another person can have a lot of worrying and rumination. A third person could have predominantly negative thinking. every person is not going to have similar kind of collection of symptoms or signs. What maladaptive process can be different in different people. Similarly, same processes can lead to different clinical presentation. For instance, I'm very close to my internal experiences. I keep watching TV in order to, so that, or say you have three different people who do not want to feel sad. So there is non-acceptance of a feeling and struggling to not feel sad. So do you think all three of them will achieve that in a similar way? One person could binge watch. Whole night I'm watching one series after the other, because the minute I switch off, I go to bed and then the sad thoughts come to me. I don't want it. What do you think the second person could be doing? They could be using substances. A third person could be that they tend to blame others, they get lose temper, they get into fights. So different, but what is that common process? The one process is that they are not open to their experiences. We need to address the process and not syndromes if we want to make lasting change in the person. So this is from a Death Star project, which looked at 55,000 different studies, mediational studies, and checked which had proven effect sizes, and checked what was it that really made the change in the person. When it changed, there was a effective change in the person, or an improvement in the person, or increased ability to cope with life. So this is presented as per the size of the effect of the mediator. So you can see the major player is self-efficacy, a feeling that I can manage, I can do it. Second one is acceptance, being open to experiences, internal and external experiences, how open we are. And mindfulness. Parenting is a major player, our belief, anxiety sensitivity, and so on. So to just categorize all these are so many mediators. If we break it down and then classify it, we will have 6 main core processes. First one being affect, our emotions, and our ability to manage our emotions. By managing emotions, it is not about controlling or suppressing emotions, but how well we can relate to our emotions, be open up, and not end up struggling with our emotions. Second one is what do we do with our thoughts? Are we able to see thoughts as thoughts? Are we able to shift attention and not get stuck to certain thoughts? Third, attention. How flexible is our attention? How can we broaden our attention, focus our attention, shift attention? Fourth is sense of self. Are we in touch with that true self, which can be unaffected by what goes on around us? I am not the exam that I failed. I am not the promotion that I got. I am not a failed marriage that I have. So whatever situations, they don't define me, but I know that there is a part of me which can traverse all this one after the other in an unchanging manner. Being in touch with that part, observing self in us. The fifth is motivation, or our ability to be in touch with what our values are and what really motivates us, and to finally take control of our action and move in that direction. Whatever human problem that there is, we can actually, not external problems, but how within the person we can actually look at it from these 6 core processes. They are functionally important because they in turn affect other processes or the way we manage our life. So it all plays a function. So if we see maladaptive processes and adaptive processes, we can actually think of, for instance, take attention. The maladaptive process would be rigid attention, scattered focus, or excessive attention to past and future, whereas adaptive would be flexible attention, awareness to refocus, and ability to be mindful. We won't go into all this, but we can identify adaptive and maladaptive processes across these 6 core processes. And we need to understand in terms of our sociocultural and biophysiological levels as well. So all this can be put into the extended EAM, or the extended evolutionary meta model. This is the model that will inform process-based psychotherapy. So you can see you have all the 6 levels or dimensions across the 2 levels of physiological and sociocultural aspects taken into consideration, and and it's definitely embedded in evolutionary science, which looks at variation, selection, and retention. Won't go into that, but anytime there is problems with variation, I am stuck and I can only think of one particular way of doing things. I'm not flexible, or I cannot select what is best. I might have different option, but I select the worst option always. Or I know variation is fine, selection is fine, but for instance, I know I need to exercise in this particular manner. I select a particular time to go. I do all that, but I'm doing it for only 2 days. So I'm not able to retain what I have selected. And all this has to be understood in context. We cannot take the person away from the context. What works for one particular person who is from, say, an educated English-speaking background may not work for a person who is coming from a rural background, who has not undergone education, who has multiple socio stressors. So if a person has to, what is adaptive or maladaptive has to be understood in context, cannot be understood away from the context in which the person is. So the EAM helps us organize all this together so that we can move to evidence-based and process-based psychotherapy, keeping into consideration all the information that we can collect about that particular individual, and yet have evidence-based interventions. We'll just take a small break. Is there any questions?
Dear delegates, do you have any questions? No, ma'am, as of now, we have not received the questions.
Okay.
We'll cross-check with the YouTube chat box as well.
Maybe we could finish and then we'll take up
Yes, ma'am. As of now, in the YouTube chat box, we have not. Yes.
Okay. So we move on to the final part of our talk or presentation, where we need to, what is process-based therapy? It is about scientific and evidence-based targeted interventions. Targeted in the sense for that person, what works, knowing what works, and with scientific evidence that it works. When we are process focused, we are individual focused, or we are catering to the person. Procedures should fit what process we want to change. Do we want to improve the person's flexible attention or attention shifting skills? Do we want to help the person open up to their experiences? Do we want the person to be able not to stuck to their thoughts? Do we want the person to become more active? What is that process that we want to make change? And an intervention has to, or multiple interventions has to focus on that and make change in that process. And what happens? Automatically, there will be reduction in the problems that the person has, and the person would achieve higher levels of function. It's not about learning more and more therapies, learning more and more manualized and calling oneself, okay, I am a specialist in OCD, or I am a specialist in this particular thing. It is good to be specialist in all this, but it's more than that. To a man with a hammer, everything looks like a nail. We shouldn't be clinicians like that, where I know this particular therapy, so let me treat everybody with this therapy. That's not how that's not a very scientific way of doing things. But at the same time, we as clinicians, we need to be able to understand what is happening in the client, and we need to be able to have interventions, be experts in interventions which will help the client. So before we go into further about process-based therapy, let's just look at how we reached here. So apart from psychodynamic and humanistic therapies, the learning therapy history we are looking at, we first had the behavior therapy. And Hayes has spoken about, Stephen Hayes has spoken about it as 3 waves. So we have the first behavior therapy, where we looked at the stimulus and the response, and the human being in between did not matter. But behavior therapy gave us solid interventions which were very based on theory, and it was grounded on theory. And why this intervention worked, we could clearly explain using theory. But because the thoughts or what went on within the head was not taken into consideration, we had Ellis, Beck come in and give us cognitive therapy, which is a very good, again, looking at, with a very clear model. Cognitive therapy has a very clear model. And then there was a big clash between behavior therapists and the cognitive therapists, a battle between them for several years. And then they finally agreed, okay, let's just join hands and we'll have CBT. What happened with CBT, as I explained, CBT got into the bandwagon of protocols which are made for certain syndromes, and the whole latent disease research team also funded CBT researchers, and CBT really proliferated, and there were a lot of, like, you know, the maximum number of researches have happened in CBT, and then they challenged the dynamic therapists and other therapists saying, where is your scientific evidence? So all this was happening. But unfortunately, as it said, when doing that, CBT moved away from theory. However, and then we had the third wave where acceptance and mindfulness. Whereas in CBT, you look at, and especially cognitive therapy, you look at the content of the thought, and the focus is on correcting dysfunctional assumptions and distorted thinking. So the content is corrected, whereas with the advent of acceptance and mindfulness, the third wave, so we have the third wave CBT also, where acceptance and mindfulness is incorporated into CBT, where it is about moving away and observing thoughts or observing our emotions and taking control of action. But one good thing about all this research in CBT is that it's not a completely failed exercise. One good thing is that we have a whole set of evidence-based interventions which came out of it. There is evidence for specific interventions. These are very comprehensive 20 interventions. If a clinician is able to be thorough with this and are experts in these interventions, the person, and they are able to conceptualize and understand the person's problem, any mental health problem can, psychotherapy for any mental health problem can be provided with these interventions. This is a hexaflex. We won't go into it, but I just want you to understand that ACT or acceptance and commitment therapy is a core process-based therapy which looks at different processes. And every problem can be understood from an ACT model. We can understand which of these processes are not really working and help. So different individuals can have different set of processes that are not working, and then interventions or exercises which help the person move that process can be provided. For instance, if the person has depression, presenting with depression or worrying or excessive negative thoughts, one of the predominant core process that the person has problem with is cognitive fusion. They are not able to see thoughts as thoughts, negative thoughts that you're not good enough, you're a failure, you're a loser. They feel like a loser, not good enough, and as a failure. So ability to diffuse is not really working. So probably the first thing that I might do is to work on the diffusion skills. So this is just to show you how when we struggle, experiential avoidance is something that causes a lot of mental health problems, especially anxiety, depression, where person starts struggling in the pursuit of happiness, in the pursuit of feeling good, starts into a emotional avoidance detour. So experiential avoidance is where the person is struggling with their own thoughts and feelings. And here again, what is the difference between these two running? Can you quickly type into the chat? What is the difference? Yes. One has an aim, one is goal oriented, one is running around the same circle. Yes. And okay. Anything else? What about the goal? What kind of goal? Is the goal same for everyone? Who should determine this goal? And on what basis do we set the goal? Okay, self. Yeah, that's a huge question, no? Thank you. Okay. So definitely a goal is important, and the direction in which we run is important. Otherwise, we'll be running around and losing a lot of energy, but we may not reach where we really want to. What I often say when trying to help people who are indecisive, or that's very common. Young people who, should I be in this marriage or should I get out of this marriage? They will be in the marriage and they'll be fighting with their partner. For 1 year, 2 years, last 10 years, I am fighting. I should have left this marriage long back. Next 10 years also you will be fighting because you have not made up your mind. Either you make up your mind to be in this marriage and work on this marriage, no matter how bad it is, or you get out of the marriage. You have to decide. So decision making and committing to one direction is very important. Okay, so coming back, functional contextualism, or understanding the function of the behavior. Now this must be very familiar, like those who are familiar with behavior therapy, we are quickly going into BT, right? Or behavior therapy principles. What is the function of behavior? We have moved off so much that nowadays, if I ask students, they'll all say ABC, but what exactly are you doing? What is stimulus control? What is the function of this particular behavior? What is the antecedent? What is the trigger? What is the function of the trigger? What is the function of the consequences? A lot of times we get lost in that. But unless we understand the function of a behavior, for instance, a young person, 5 different young people. Nowadays, self-injurious behaviors, cutting behaviors, and all is very common. But we cannot treat all these young people or help them manage it in the same way. Each person, it might be the same behavior, but the function could be very different. For one person, it could be experimenting. I like to do it because my friends are also doing. For another person, it is an expression of anger. Whenever I fight with my parents, I go and cut myself. Serves them right. For a third person, it could be, my parents don't listen to me at all. Only when I do something like this, they sit back and listen to me. So it's getting attention, which is not a bad thing, but that is a function of that behavior. For a third person, it could be to relieve oneself or distract oneself from the emotional pain, which is intolerable. The cutting and that physical pain helps me distract myself from the pain within. Will you handle all of them in the same manner? Will it work? No. So we need to understand the function of the behavior in order to help that individual. What is the function of what the person is doing? What is the role of that for that person? We won't go into it, but this is a typical way in which we help along with the client. We do functional analysis so that the client also understands what is happening with them. The purpose of this is a lot of times what a client might do has a function, is helping the person, but in the short run. I don't go to college. I feel very relieved. It might be helpful today, but is it really going to help you the whole year and your whole life? So what we do with is very helpful in the short run, may not be helpful in the long run. So a good understanding of this is not only essential for the treating person, the client also has to understand what behavior they are doing and the consequence of that behavior and why they are doing. So to coming to process-based therapy, it is not yet another form of therapy. It is a model. It is a meta model. You can do whatever therapy you want, but you can have a process-based understanding of what you're doing, rather than hitting in the black, saying I'm doing this therapy and somebody said it works. Can you organize all the information that you are collecting from your client, and can you use those interventions which are specifically going to help that client at that point of time with that particular problem? If we can do that, it's going to improve the effectiveness of the treatment, as well as the practitioners is going to be so skilled. You're not going to fit one size for everybody. You're going to give a tailor-made psychotherapy. And process-based therapy is individualized. It uses a network conceptualization, which we'll see. It's holistic, based on the 6 core processes which we saw. It utilizes evolutionary model and is rooted in evolutionary science, and it is data driven. We can very easily, on a session to session basis, know whether we are making a change in the person. So just to give you, show you how the network conceptualization works. This is a 29 years old single female doing PhD in Germany. And last 3 years, she's doing her PhD from a middle socioeconomic status, hailing from Kerala. There is family history of worrying in mother, perfectionism in father, highly anxious. She worries of making mistakes, something going wrong, worrying that something will go wrong, and fear of criticism and high avoidance behavior. She came to me at a point when she was struggling and losing hope with her PhD. So without going into too much details, if we look at the kind of symptoms that she has, she can be diagnosed as having generalized anxiety disorder. She can be diagnosed as having social anxiety and mild to moderate depression. And we also know that there are parental models or parental contribution to her problem. For this person, a generic CBT model, which looks at the dysfunctional thinking and how the physiology, behavior, and subjective experiences are interconnected and feeding back into the negative thoughts, may not do. We need to have what is really happening within the person, unique to this person, and understanding of all those aspects. So we won't be going into how we built this. Just look at the network conceptualization for this person. What we have is parental anxiety in mother and perfectionism, criticality contributing to the anxiety. And you have anxiety and worrying in the center. Then you have another loop, which is talking about the social anxiety that the person has. Then we also have the continuous worrying about things going wrong and how much she spends her time within her mind. And then what happened was, when there was lack of progress in her PhD, which is increasingly started noticing in the last 3 to 6 months, she also developed sadness, feeling that she is a failure, hopelessness, which led to further social anxiety, avoiding seminars, avoiding her supervisor, avoiding her peers, spending more and more time inside her room. She was not able to do her research work. So what we need to understand how each of this is functioning to contribute to the other. We need to look at what are the maladaptive processes working here. So there is experiential avoidance, there is avoidance behavior, there is dysfunctional thinking, there is excessive rumination or excessive attention to future rather than the present. And we need to know what methods or intervention should I use for this particular person. What do I do differently for this person? And I have interventions which were listed earlier. I will be targeting these problems with those interventions in the order that whichever is causing maximum problem. If you see here, it is anxiety and worrying and experiential avoidance, which is so much connected to or contributing to other problems. So I might address the experiential avoidance first. And finally, as I said, it is data driven. I want to know whether my interventions are working. I don't want to just hit in the dark and say, okay, I hope it worked. I want to know whether this session made certain changes in the client. And process-based therapy can actually help in assessing what process I am targeting and what change I am able to make. So these are the references. Any question? I would definitely say that if when I am a student, if someone came and said all this to me, I would not be able to make real sense of it. But somewhere probably I'd be happy that there's a whole lot of things going on out there, and there is so much exciting work that I can do. So I think the purpose of my doing this presentation in this way is to generate curiosity in all of you. And it is meant for all of you who are bold, who can challenge and ask questions, who can't take it just lying down. You said, so I accept. Not that way. I will question you. I want to be convinced. And definitely all of you who came to do psychology because you want to understand about mind, because you want to help people, process-based interventions, and these being grounded in theory, targeted interventions, learning targeted interventions, learning to conceptualize problems will definitely help you. Any questions that you have?
Thank you so much, ma'am. It was truly an informative session. So participants are now free to ask questions regarding the topic to a resource person in the chat box.
The participants may also unmute their mic and ask questions directly. Please feel free to ask questions if you have any. Ma'am, that was definitely an enlightening session. Rather than focusing on the syndromes, we're looking on to the processes. Ma'am, could you kindly, mention about the status of this process-based therapy right now in India, and especially in Kerala context?
I wouldn't say that process-based intervention or process-based approach is entirely new. A good clinician actually looks at what is not working within the person and looks at what evidence-based interventions are doing. Only thing is, we all, including me, we were struggling with it. It was a personal struggle. Each person has to find that balance ourselves. Then we had transdiagnostic therapies coming in, unified protocols coming in, and we are at the wave where evidence-based therapy is really unfolding. So this is what is happening in all around the world. So why should India fall behind in anything?
We do have 2 questions. How
Yeah.
is progress measured in process-based psychotherapy? It's from Sarah.
Okay. So as I showed you, it can be done by the therapist, it can be collaboratively done or self-reported also. So we are essentially, supposing you are teaching mindfulness for the person, and you have understood that mindfulness is the intervention. The person is too much in the past or worrying about future and really not focusing on what's going on around. And I'm just doing mindfulness intervention for the person because I've felt that mindfulness is what would be most helpful. I am going to assess mindfulness. Can I assess mindfulness for the person? Is mindfulness changing? I can assess using questionnaires. I can actually assess by my own observation in during session. I can measure that also. I can rate it or measure that based on the verbalization that the person is saying, right? So the multiple ways in which I need to know what intervention I am doing and what process I want to change. And I need to know if there is a change, what is the difference that there will be in the person. I can quantitatively or through observation assess that. And similarly, I can assess all 6 of the dimensions: attention and mindfulness, ability to manage cognition, ability to manage emotions, ability to be motivated and be clear about one's values, ability to be comfortable with oneself and not allow situations which go up and down affect a person, and ability to take control of action. If I have to get up from bed at, say, 6 p.m., I should be able to do that. So that can be assessed.
Yes, ma'am. We have another question from one of our PG students. How has the research supported the effectiveness of process-based psychotherapy? Ma'am, you have mentioned about this during the class, but
Yes.
we have received a question again.
As I said, process-based therapy is not a completed, evolved, finished product. Process-based, more and more world is looking at process-based psychotherapy, and here we have scientific evidence for the interventions that each intervention which is utilized, all that has evidence. They are evidence-based. So for instance, if I say exposure strategies have evidence. If I say mindfulness has evidence. Now it is more and more, there is increasing research base which is coming in for process-based therapy, but I would say that we definitely have a long way to go in utilizing process-based as the meta model that clinicians are using and proving effectiveness. How does psychotherapy address the concerns of patients who feel that their treatment is not addressing the root causes of their issues? Definitely, clients are feeling not understood, or our ability to give them a feedback about what is really happening within them. Somewhere we are failing in that. So probably we'll have to find out what they call as the root causes. And process-based psychotherapy, or say even ACT, we work with in terms of behavior. So when you say your root causes of your issues are not understood, can you tell me, if I am understanding the root causes and if I am helping you, what is the change that you would be able to make? So you see, I am moving into from a very abstract, very subjective experience that the client is reporting to a behavior so that I can work with the client and understand what change the client wants to make. Yeah, this is a very good question, Neetu Mole, because a lot of times clients do say this. Can you give an example of a process-based intervention that a therapist might use? All these, so like I said, process-based intervention, say diffusion, all these 20, let me show you. See here, these are mindfulness is a process-based intervention, which is targeting this client's inability to be in the present and always be in the future. Or a cognitive diffusion is an intervention which I would be using in order to help the client not get stuck to the thought of I am going to seem awkward, or I am going to definitely make questions, because if I'm stuck to the client is stuck to that thought, she's going to avoid doing her seminar or presenting her work or meeting her supervisor. So these are all interventions. These are all strategies or interventions which, if we understand what maladaptive process is happening, and with these interventions, we can lead to make a change in the person and help with adaptive processes. So you have all these processes which are, say, for instance, self-criticism leads to a lot of negative sadness or feeling low. Can I shift with these specific 20 interventions can help in moving the person towards more self-compassion, more acceptance of oneself, from hopelessness to hopefulness. So processes can be changed with these interventions. How does the therapeutic relationship play? Therapeutic relationship, as in every good psychotherapeutic relationship, the therapist has to be open, understanding. First of all, we should not be stressed, which is a very difficult thing in current world. Ability to understand what the client is saying, ability to pace oneself at the pace that the client is comfortable, ability to have a framework of where we are heading. So a good training and a good therapeutic skills, which are common to all therapies, and all the more in ACT in particular, or process-based CBT or process-based ACT, we have a very equal relationship, no hierarchy there. I am also a struggling human being. With my training and experience, I am open to let us form a team and work together. So no one-up working. And also, which is also very difficult in our setting, because in India, we always have clients who come in seeking the guru or the person who can give them solutions or help them very quickly. So all the more moving to that equal relationship is difficult. And also an openness to see from the client's perspective itself. That is very important. A lot of times, which is not an easy task at all, because all of us come with our own biases and our own life experiences, our own prejudices, our own understanding of what works in life and how life should be. So being able to keep all that aside and then being able to understand the struggles of the client from the client's point of view, where the client is coming from, an unlimited amount of patience. These are all necessary in the good therapeutic relationship.
All right, ma'am. We don't have any further questions left. The feedback forms are posted in the chat box. All the participants are requested to fill out the feedback forms, and please make sure to check the spam folder as well in case if you do not get the certificates. Ma'am, we'll proceed since we do not have any further questions.
Okay. I particularly want to thank all those participants who actively participated and put in your valuable words into the chat and ask questions. Thank you very much. And I would like to thank the organizers and giving me this opportunity to be with the wonderful students in Kristu Jyoti and all other students or people who are participating. Thank you so much.
It's our honor, ma'am. We do have a cucumber watching from the YouTube live as well and from countries abroad. I guess we'll proceed. All right. Anu?
Thank you. Thank you.
Thank you so much, ma'am. So now I invite Miss Dora Baby to deliver the words of gratitude.
Hello, am I audible?
Yes, Dora. Yes.
A very warm evening to one and all present here. Honorable resource person, Dr. Gitanjali Natarajan, respected principal, Reverend Father Joshi Chiramkuri CMI, delegates from the Institute, and my dear friends. It is a great honor and pleasure to be chosen to deliver the vote of thanks on this auspicious occasion. First and foremost, I thank God Almighty for giving us the opportunity to successfully complete the active conduction of the webinar. A wide round of applause and thanks to our resource person, Dr. Gitanjali Natarajan, who took out her precious time from her busy schedule to impart knowledge about the various aspects of psychotherapy. Thank you so much, ma'am. Next, I would like to express my sincere gratitude to our principal, Father Joshi Shiramkuri CMI. Without his support and guidance, this program would not have been fruitful. Thank you, Father. I also extend my thanks to organizing committee and also the coordinators, Ms. Sharon Jones, Assistant Professor, Postgraduate Department of Psychology, and Ms. Gayatri Jones, Student Coordinator, who have put their time, effort, and energy into making sure that everything goes well organized. Thank you. Finally, I would like to thank you, every one of you who have attended the session. Thank you for your valuable presence and attention throughout the same. Once again, thank you all and have an amazing evening. Thank you.
Thank you, ma'am. Dear participants, the session is now over.
Thank you, Dora. Now we have come to an end of our session. I thank everyone on behalf of Kristu College. Thank you.
If we have any participants who have not yet completed the feedback forms, we request you to kindly fill out the feedback form at the earliest. And please do make sure to check the spam folder as well to get your certificates in case if you have not received it directly to your account. Thank you so much for joining with us. The session will now be ended.